Welcome back. Today we're going to begin the first of two lectures on what are called the special senses. These are special because they're really unlike anything else in the body, and these are the senses today of the eyes and eyesight, and at the next lecture on the sense of hearing and balance. We're going to skip a couple of special senses. We're not going to have a separate lecture on smell or taste because they're very small topics that you could probably read more easily on your own. But the eye is a very complex structure, and we actually don't have the top of the line evolutionarily here. We have a very good eye, but if you look at an antelope, for example, who has 8 times magnification in its lens, it can see things very far away. That's why they live out in the plains, where they can see their predators from a long, long way away. We do have something very special. Predators such as we have binocular vision. This is extremely important. The predator needs to be able to judge distance very accurately. We can judge a little bit of that distance by the size of an object and how far away it is from us. But remember those proprioceptors in the eye. We can look with our 2 eyes and focus on a very near object, and the brain knows and interprets unconsciously that the angle is very sharp here, and that object is closer. We can move the object farther away and look at it in the distance where our eyes are almost parallel, and the brain will know that distance. It's very good at judging distance. If you lose vision in one eye, you lose that ability to have what we call depth perception. And in fact, if you take a finger out here, close one eye, and try to touch it on the first shot, you'll probably miss. You'll then be able to make corrections and hit it. And we run into this, for example, as surgeons when we started doing laparoscopic surgery, which was done through a fisheye lens on a television screen, and all of a sudden our depth perception was gone. And we had to learn how to judge distance purely by size, and a size that was distorted. Neurosurgeons who work through very small holes can only get one eye looking down that hole at a time, and they have to learn to judge distance. So binocular vision is very, very important to our survival and to our ability to function in fine, detailed ways. Now, if we look at the first slide, I'm going to go over the anatomy very carefully. This first section is taken as a horizontal cut through the left eye. So if you look at me, this slice is going straight through the left eye, and we have lifted the top away, and we're looking at the bottom half, sitting in the bottom of the orbit. Since this is the left eye, the nose will be right up here, and the temple is here. We call this the temporal side of the eye. We call this the nasal side. And the other thing that's important to keep in mind is that the orbit itself, the bony circle and the compartment that holds the eye, is not facing straight forward. It's actually facing at a slight angle out. And if you look here, you'll see that the optic nerve, which comes back to the brain, is following that cone. But the eye itself is looking straight forward. This has a lot of significance when we have eye movement, and I'll get to those later in this lecture. Let's look first at the different parts of the structure of the eye, and as you can see, there are really a great many. Starting out here where the light comes in, the first thing we have is a very thin layer called the conjunctiva. This is a layer of one set of cells that covers the entire surface of the eyeball. It's completely clear. It can get what's called injection. It has blood vessel supply, especially near the periphery, but not over the lens, so that you can get a bloodshot eye. And the conjunctiva is continuous with some other structures. It comes up on top and then comes off the eye and goes out onto the eyelids. So when you think about it, if you wanted to reach in the back and come back here to work on the eye, you'd have to go through that conjunctiva right here where it turns and goes out onto the eyelid. You'd have to make an incision, make your way through that space, and then sew it up when you were done. Under the conjunctiva, which is very thin, is the thicker layer called the cornea. Now, the cornea has a shape to it. You can see it's kind of a hemispheric dome. And it has the function, number one, of protecting the eye. It's the outermost fibrous layer, and it is also something that gives some shape so that it can focus light, because it's curved. Even before light gets to the lens, there's a little focusing going on in the cornea. It's actually the most frequently transplanted tissue or organ, because it is an organ system in itself. First of all, because it's readily available. We can take this from a cadaver at any time immediately after death and get plenty of them for use. It doesn't matter almost how the patient died. We can get the cornea. Second of all, it's avascular. It doesn't have any blood supply. It receives all its nutrition by diffusion. I mentioned earlier in the course when we studied blood vessels that we don't want a blood supply in our cornea. We don't want to be looking through rose-colored glasses. So this also helps us in transplantation because there aren't a lot of antibodies circulating there, and therefore the cornea doesn't get rejected very often. By now you know it only contains pain fibers, so that anything that touches the cornea is perceived as pain and reflexly closes the eyes and creates tearing to get rid of it. A sudden wash of tears to flood anything away. Obviously, sight is a very important sense, and the body does a great deal to preserve it. Now, if we look at the next layer, we have something called the sclera. The sclera encircles the globe. The eye is known as the globe, and it's this very, very hard layer that's almost continuous with the cornea in front. But now back here, it's hard and it is not transparent. It's white. It is what we mean when we talk about wait until you see the whites of their eyes. The sclera is a supportive and protective coat, and it maintains the shape. It provides some structure for the eye, some support. Coming now more internally, we come to a system called the uveal system. It's the middle layer of the eye, and it provides vascularity for the eye's structures. One of the most important parts of the uveal system is the iris. You see it here on cross-section, but it actually is seen better in this slide where we see what it really is. It's the shutter of the lens of our eye. It's just like a camera shutter, and it is composed of two kinds of muscle fibers. It has radial fibers. Remember, when muscle contracts, it only contracts in one direction. It can only shorten, and then it can relax back to normal length, but it can't forcibly lengthen. So in order to be able to move the iris open and close, you need two sets of muscles. So in the iris, we have the radial fibers, and we have circular fibers. Now in normal light, here is the pupil. Pupil is really nothing. It's the hole in the donut, just the opening. The pupil is at mid-range. If you need more light, the sympathetic fibers of the nervous system will fire, or if you put a drop of adrenaline in the eye, it'll diffuse right across the cornea and into the uveal area, and it will cause contraction of the radial fibers and open the pupil, allowing in more light. If, on the other hand, you fire the parasympathetic fibers, you'll get constriction of these muscles and relaxation of the radial fibers, and these circular muscles will narrow the pupil. And there are drugs we use here quite freely in medicine clinically. For example, patients who have certain diseases need their pupil closed. One of those diseases is called glaucoma, and I'll tell you a little bit about that. But basically, we want a narrow pupil, and we put long-acting parasympathomimetic drug in there. It mimics the parasympathetic system, and that keeps it closed. Narcotic drugs are parasympathomimetic. So when we look at a drug addict in the emergency room, what we almost always see, somebody coming in with an overdose who's unconscious, we won't see a dilated pupil, where many patients have that when they're unconscious from head trauma. What we'll see is narrow pinpoint pupils. We go, aha, this patient has a drug overdose even before we get the results back from the laboratory. We also have in this area something called the ciliary body at the very edge of the uveal tract. We have a ciliary process and ciliary muscles which attach to the lens. The lens is our second avascular structure in the eye. It gets all it's very metabolically very inactive, and it gets all its nutrition and excretion of wastes from diffusion. It has shape, and it focuses light that comes through it. It is pulled upon by some of these ligaments, and it gets its blood supply to the uveal tract as well as the ciliary processes by vascularity that comes into this layer. This is a very, very vascular layer. As we go back in the eye, you can see some of the muscles where they attach to the scleral surface of the eye, and we'll go through those in detail. The next layer in from the sclera, here's the thickened sclera cut. Here's a representation of what's called the choroid, which is almost entirely blood vessels. This supplies the vascular supply to the retina, which is the inner layer right here. Blood comes in, and it runs through the choroid and then comes out onto the retina. We can actually see through the retina and see those blood vessels. Now, when we look at the eye, we get a very good view by looking in through the cornea and the lens to the back of the eye, and we can see this whole area back here. One of the things we can see is this layer called the retina, and this is basically the film that light hits and produces the vision for the brain. It's not the last thing we look at. It's almost more like the negative because it's going to send more information back to the brain, but it's the beginning of our perception of light. There's some more structures you really want to know about here. This is called the optic disc, and this is the place where the big optic nerve number 2, comes through from the brain and enters the eye. The nerves then spread out on both sides, actually in 360 degrees, all around the retina. And all the impulses are going to be channeled from the retina back here to the brain. It also carries the blood supply. Here's a single artery, single vein. Bad situation, isn't it? We only have one vessel. If you knock off this vessel, that's it for that eye. So nature here has chosen not to put too many vessels in this area because every vessel takes up room where we might be receiving vision. And so we only have the one, but we do have two eyes. Where the nerve penetrates the retina and where the vessels penetrate the retina is known as the blind spot. Notice there's a good reason. It's not right in the middle of our axis of vision. It's off to the nasal side. That blind spot is there because there's too much stuff going on. It's the exit of the nerves and it's the exit of the vessels, and the retina, it just doesn't have any room to function. So we have this small blind spot, but they're not symmetric. If you'll notice, it's on the inside of this eye, and it would be on the inside of the other eye, which would be covered. Therefore, each eye has a little overlap, so our blind spots are canceled. When we look around, we're not aware of any blind spot. However, you can prove you have a blind spot if you draw an X on the wall, and a short way over, put a dot. Cover your left eye and look at the X, and then move that dot in and out. At some point, the dot will disappear. And now you've put the dot right in front of your blind spot. With both eyes functioning, you're totally unaware of it. Now, as we move on, the retina actually contains all the receptors for vision. It retains something called rods and cones. The rods, of which there are about 120 million in each eye, are photoreceptors shaped like a cylinder, so they're called rods, and they receive black and white information only. They can see in shades of gray, and they can see in very dim light. So they are there at the really primitive level where we need to see for survival. We're in the dark, and they can perceive movement and shape very well in conditions where we might not be able to see color vision. If you go out at night, you'll notice one of the things you will lose as it gets very dark is you start to lose your color vision. Very much like in the early forms of photographic film, our most sensitive films were black and white. The cones are the color receptors. Now, the rods increase in number as you look peripherally out here in the visual field. Actually, we have to talk about peripheral field and we have to talk about part of the retina. I'm going to talk about the peripheral vision field because that's easier to understand. If you look at this for just a moment, if light comes in from the temporal side, my peripheral field, and comes through at an angle through the iris, it's actually going to end up on the medial side, the nasal side of the retina. But the brain knows that. So let's just talk about what we see. The reception of the rods is best for light in our peripheral field in darkness. There's lots of rods out there and not a lot of cones. This is survival stuff again. Hunters know in dark settings not to look directly at their prey. Some people say that's because the prey can tell you're looking at them. That may be, but it's really because they're going to get better vision in their peripheral vision. They'll look a little bit away from the prey and see the prey better in their peripheral vision. We think the prey animals do the same, as well as the predatory animals, because they have unconsciously adapted to seeing best in dark situations. We have 120 million of those. We have about 6 million cone-shaped receptors. I'm going to show you these in a minute. And these receptors are for color vision, and they need much more bright light conditions to be able to see. We don't see color, as I said, in dim night vision because they just don't function. They don't have the energy, they don't have the chemistry they need. And then if you look at this slide still again, there's a very thin area back here called the macula lutea, the yellow spot. Now, the macula lutea is an area where the retina is very, very thin. It's at the very center of the retina. It's where the most important part of our light is going to come in. It's called the central fovea, which is a depression, and you can actually see the retina come down, thin out for a little depression, and pick up again. It provides the clearest vision. It's basically where we can see almost to the back of the retina, but more important for vision, it's the place we see best. Now, the ophthalmologists and medical doctors look at the eye as really a window to the whole neurovascular system. It's the only place in the body we can look in and actually see things functioning. You've all, I'm sure, been faced with an ophthalmoscope. Doctor puts the light to his eye, gets really close to your face, and shines a light right in here. Sometimes in the ophthalmologist's office with the help of a vasodilator, a sympathomimetic drug like adrenaline to open your eye up, and then looks back and he or she can see the entire surface of the retina, so they can see if there's any problems in the retina, and there are lots of diseases that are diagnosed by their retinal damage. For example, diabetes can be diagnosed by retinal damage. They can also see the vessels. And they can actually see blood circulating in the little veins and the arteries back there. And when somebody dies, the pressure drops and these vessels collapse. And in places between the blood where they collapse, it looks like little boxes all lined up like a little train. We call those boxcars. And when you look in the dilated pupil of somebody who you think is now dead, you can't feel a pulse. You look in that eye. When you see boxcars and no movement, you know that patient is dead. That's what the doctor's looking for. We also look for the lack of reflex. The pupil dilates at death because of that last rush of adrenaline, and then when you shine light in, there's no reflex. That's really a very good indication that there's something really wrong with the nervous system. We also have several chambers in the eye. And the eye is not just one big balloon filled with water. If you look up here, we have something called the anterior chamber. You're getting to hear that word a lot now. It means the one farthest in the front. And a posterior chamber that's right behind the iris, right there, all of which are in surrounding the lens and in front. This is filled with something called the aqueous humor. It's a very watery solution that exchanges rapidly. About every 90 minutes, there's new fluid going in and fluid coming out. It bathes the lens and the uveal tract and the cornea with a fresh supply of nutrients and oxygen all the time in lieu of a blood supply. There is a tiny opening back here called, if you can just see it, called the canal of Schlemm. Let's take a little closer look at that, because the canal of Schlemm is going to come up in some of our discussion of disease. And this picture is showing you now the cornea. Here's the iris of the eye, the lens. So this could be either a horizontal or a sagittal section. We don't really know here where the eyelid is, but it doesn't matter since we're dealing with a globe. Here are the suspensory ligaments of the lens that can tighten and stretch out and change the shape of the lens when pulled upon by the ciliary muscles. And there is a circulation that comes out of this ciliary process, circulates around, and goes out back through the canal of Schlemm. I'll talk to you a little bit more about that, but basically, if you get too much pressure built up here, either by overproduction of aqueous humor or by failure of the canal of Schlemm, then you get what's called glaucoma, increased pressure in the eye. This is transmitted back in high pressures toward the retina, can put pressure on the vessels and injure the blood supply. So glaucoma can be a very serious cause of blindness if it's not treated. Now, we have ways of treating it with drugs that reduce the amount of aqueous humor, that lets you get rid of it faster. We also have a drug that prevents the iris from opening widely. You can see that this angle in here is very near the canal of Schlemm. There's something called angle closure glaucoma, in which this angle gets closed by the retraction of the iris and the bunching up of the muscle closing off that canal. So patients with glaucoma are given a drug called pilocarpine, which is parasympathetomimetic and keeps the pinpoint pupil, same thing you see in the drug addict, but keeps this open and allows that to flow out and keeps the humor from building up too much pressure in the eye. Now, getting back to the chambers of the eye, so we've seen an anterior chamber and a posterior aqueous chamber. Then the rest of the globe is filled with something called the vitreous. And the vitreous is not so watery, it's much more jelly-like. It is contained completely back here in the posterior chamber. This patient has a parasagittal section. In other words, if you remember the sagittal cut through the face, we move out to a parasagittal cut. And now you'll know that this isn't quite in the middle of the eye, is it? Because look, it's gotten to the optic nerve. It's cut right through the optic nerve, so this must be nearer the nose, correct? So if we look back at one, you'll see this section must have been taken here. It's actually an artist's rendering, and it really isn't so accurate because we're clearly from this looking very near the middle of the eye. They're just putting this as a representation. Anyway, the vitreous is back here. The vitreous does not exchange. You have most of the vitreous that you're going to have for your whole life. It's not like the aqueous humor. And what it does is it presses against the very filmy, delicate retina, keeping the retina under pressure all the time, flat against the surface where it needs to be. What happens when there's an error there? For example, if you have an injury, sudden deceleration, blunt injury to the eye, you can get bleeding or just deceleration that can tear a piece of the retina off the back wall, off the choroid, and have it flowing out into the eye, bulging out. Now, this may disrupt its blood supply, and that area of the retina may die, and you'll have a bigger, different blind spot in that portion of your whole visual field. We measure people's visual fields. You look at a blank screen with a grid on it, and the doctor will bring, you look straight ahead, doctor brings in different colored objects, and you tell him when you see it, and you can measure the shape of the visual field, and you can detect blind spots. Also, we have machines that can do that now a little more easily. If the retina comes off, even if it has not become devascularized and still has the ability to function, it will be as if you hung a sheet to see a movie and somebody's made a bulge in that sheet. It's going to distort the vision in that part of the eye, so you will have blurred vision. The lens, after all, is using its ability as a focusing agent to focus a point of light precisely on each point of the retina. Once you move the retina, the lens is still focusing where it thinks the retina is, and you'll have blurred vision in that area. The other problem with having a retinal detachment is it's as if you took two pieces of balloon that were glued together and are in a watery substance, and once you elevate one edge, it's going to be easier to elevate the rest of it. So the retinal detachment may increase with time, any minor trauma, and so we do surgery for that. It's a surgical correction. There's something called a scleral buckle, where, for example, if this end of the retina were detached and bulging, what we're trying to do is just prevent further bulging. And the doctor goes behind the eye and puts a cylinder of synthetic material and buckles the eyeball in and fixes it against the retina, so it won't move any further and it may heal together, rather than letting it float. They sometimes can use lasers to go right through the eyeball and tack the retina down. There's all kinds of new surgery for this and new treatments. It's very delicate, very specialized. Eye doctors now who do retinal surgery usually just do retinal surgery. They actually super specialize into lens doctors and uveal doctors and lid doctors and retinal doctors, not just general ophthalmology anymore, because it's become such a specialized field. And it deals with something that's very, very dramatic to us, and that's the preservation of our eyesight. Let's move on now to the muscles of extraocular movement. Just in passing, we do know that a very important structure is the eyelid. It is, you see it has muscles here that open it and allow it to close. It's controlled by the extraocular muscles. This one is called the levator, which means lifter, palpebrae, which means the lid, superioris, upper. And then we have an inferioris muscle, which will pull the bottom lid open. The eyelashes are there to filter out, very important, but they're there to filter out dust and particles that may get in and to sense they're coming. As soon as the eyelash is tickled, it will tell the brain something's coming and shut the eye. Happens very fast. We also have in the eye, in the upper outer portion, a duct called the lacrimal duct, which is right under your lids back here under the bone. You have a drain right in this side, and if you go in front of a mirror and pull your lid open, at the very corner of your lower lid, you'll see something called the punctum. And the punctum is a little hole that drains down into your nose. In 24 hours, you secrete about 1 cc constantly of a little fluid that drains down across your eye diagonally from the upper lid to the lower and out the punctum and is absorbed in the nose. Obviously, when you cry or you tear, that's why your nose starts running. You're just putting too much of these lacrimal secretions in there. They contain enzymes and antibacterial solutions, and your lids act as the windshield wiper. So again, another very complicated system set up so that we can preserve the function of the eye. Let's talk about the eye muscles a little bit now, and then we'll look at the physiology. The eye muscles are 6 on each eye that move the muscles, that move the eyeball itself. If we look at this picture, we've now removed almost everything except the skull and the eyeball and its muscles. If you see, you have on this eye, this is the right eye. This is the lateral rectus muscle. It's going to take the right eye and pull on it and move it laterally. At the same time, the medial rectus muscle on this side is going to relax, but on the other side, it's going to be pulling the left eye over. So the two rectus muscles act in coordination. One is inhibited and one is innervated. The other one's going to move this way to move the eye in the other direction, lateral rectus, medial rectus. You have muscles above and below, superior and inferior rectus muscles. If you pull both inferior rectus muscles, you will look down. Superior muscles, you will look up. We have oblique muscles too. Remember I mentioned the trochlea muscle. If you look here, here's a muscle coming from the upper inner portion of the right eye, goes through this little pulley called the trochlea, and goes back to the back edge of the eye here. If your eye is turned in the medial direction towards your nose, the trochlear muscle is going to come out and pull it down. So when I'm looking with my right eye to my left side and I look down, that's really mostly the trochlea. That's nerve number 4. If I'm looking straight ahead, however, as this person or skeleton is doing, if I contract this muscle, I'm going to rotate the eye. Now the eyes actually do rotate a little bit. It's very hard to see. If I asked you to rotate your eyes, you would laugh at me. But you can do it. You don't know you're doing it. And the question is, why? Why do we want to rotate our eyes? The answer is very simple. The brain does not like the horizon to be anything but flat. In any position we're on, the brain likes a flat horizon, which is why you get seasick. That horizon starts moving, the whole body reacts to it, and it requires a lot of adjustment. Same thing sitting here. So if I turn my head, I'll notice that I still see everything right side up. There's a little bit of give in the eye, which is going to go in the opposite direction to stabilize my horizon, and the brain will do the rest. The brain will compensate for much greater. If I move my head way down here, my eye is not rotating that much, but the brain will help correct it for me and let me know which end is up, as they say. These are the muscles of extraocular motion, and they are very important in lots of different areas, in visual fields, in keeping our environment stable. There are motions, for example, that the brain prefers. The brain does not like to see things in a blurred manner. If you're in a train and you're passing a series of telephone poles, you look out the window, the brain does not want to see a blurred bunch of poles. What your eye will naturally do is lock on a pole, follow it back, and then skip to the next pole. Follow it back and skip. If you look at someone's eyes who's looking out the window, you'll see slow, fast, slow, fast, slow, fast. That's called nystagmus. That's normal in a speeding train. There are patients who are sitting still and have nystagmus. Very fine movement, and it is diagnostic of certain disorders of the senses of balance in the inner ear. A patient who has an abnormal nystagmus when they shouldn't have it usually needs a further workup and usually will be found to have something wrong with their organs of balance that have now uncoordinated the eye. Let's move on now and look at the photoreceptors of the eye. And first I want to show you a picture of the visual field as the brain sees it. The brain has a visual cortex in the occipital area. Here's the two eyeballs. We're looking down from the top. Here are those optic nerves crossing at the optic chiasm. Remember, we saw the pituitary gland back here. Burn this into your brain. I'm going to tell you all about this and explain to you how David was able to kill Goliath when we talk about the pituitary. Now, remember that vision coming from the right side of your visual field strikes the medial side of your retina. It then comes down and travels along the inside path here and then crosses over to come on this side of the same nerves, goes back to a part of the brain called the lateral geniculate body. That just means knee-shaped body because it looks like the bend of a knee. Then goes out to the cortex in the brain and is projected. And this yellow swath that was shaped like a saber tooth here on the right lateral lower visual field, looking at the movie screen, is out here in the brain, looking similar but totally displaced and separated from other things in the same field. This whole jumble has come from this field. Here's the overlapping of the two eyes, and here's where each eye has its own peripheral vision. And look at the way it comes out in the visual fields of the brain. The miracle is the brains can make sense of this. It puts it all back together, so we actually see, when we look, we see this picture, even though it's all divided up. Now, it's also upside down, so everything is upside down and backwards on this screen right here of the retina, and it's then translated as it goes back to the brain. Those are the visual fields. If we next look at some of the structures in the chemical physical world of anatomy, this is the retina. Now, this is the full thickness of the retina. Retina is very thin, filmy thing. You could barely feel it between your fingers if we took it out. It's as wispy as a fine piece of silk, maybe even thinner. There are two types of receptors. There are the rods, as I mentioned, and look at this nerve cell with its nucleus and its swelling. It has mitochondria, shown here, which are the energy-producing parts of the cell, and then it has this funny shape, which goes back onto other cells of the retina. We have the same or similar type of situation with something called a cone, and they're named basically for this part of the apparatus. Now, there is a very, very complicated physical, chemical, and electrical reaction that goes on when these cells are stimulated. What happens here is energy enters the eye and stimulates these cells in some way. This is light energy. These are photons. They will either stimulate the rods in the black, white, gray vision or the cones. The photoreceptors convert that energy into chemical energy. The chemical energy then comes back down into nerve conduction in a vitamin A dependent pathway, and this is why vitamin A is important for both normal vision and especially night vision. And the signal reaches the neurons and are transmitted down the cranial nerve number 2 to the brain. It involves certain chemicals called rhodopsin and other chemicals in the brain. It's a vastly complicated system, and it's very fascinating. I only wish we had time, but we could spend 2 or 3 lectures just on that chemical conversion and the disorders of that chemical conversion. I strongly suggest what you do is take our recommended textbook, the Anatomy and Physiology book that's in the bibliography by Totora and Grabowski, and read that on your own time. It's got wonderful illustrations. It's very clear and concisely put, and just more than we can get to in this lecture. Now, if we look at the another view of this, this is the picture which is very similar to the last one, but just blown up, magnified a little more. Light is coming in this way, and this is where I just don't want you to be confused when you look back at this again. Light is coming in, and it's going, this is the retina. Here's the outer surface with the blood vessels sitting there, and here's the back surface of this very thin membrane. Here we have some neural cells. Light has now come in and is stimulating the rods and the cones, and a reverse flow, the direction of the visual data is actually going out this way. And then it will go propagated down along those nerves to the optic nerve. The cones, as you may or may not be able to see in this situation, there's that whole point of convergence and divergence again. The cones need to pick up lots of light, so they need more receptors to get the light. Therefore, it's like that example I gave you about putting 2 fingers on the back or 2 fingers on the tip of your finger. It's 2-point discrimination. We call this in the eye resolution. The cones require more light, perceive color, and maintain higher resolution at the expense of sensitivity. The rods, on the other hand, may be able to tell shapes, but there's going to be more blurring of that image because the rods are able to perceive things in a lower light, but they're going to pick up movement and shape better than the details of color. Now, the two work together, and in normal circumstances, we have very fine, clear, sharp images. So the cones, therefore, are one-to-one, and they're sacrificing sensitivity for sharpness. The rods are many multiples of input to one. They're going to have sensitivity, but they're going to lose sharpness. The next part I want to talk to you about is what can go wrong with these areas. We've already mentioned glaucoma, and we've talked about how that's treated and how the anatomy works in making it happen and what can go wrong. We've also talked about retinal detachment and the type of surgery that can happen to correct that. There's another area called cataracts, which I'm sure you've heard about. Cataracts are probably the leading cause of loss of vision in this country, and they are merely opacities inside the lens of the eye. They can be caused by lots of things. You can get a cataract by physical trauma. A blow to the eye can injure the microstructure of the lens and cause loss of vision there. It clouds, it's usually very slowly, but you get a clouding, so you'll get some light, but because the focusing is no longer accurate, because there are particles in the way, you get a clouding of the vision rather than total loss of vision. Things become blur. UV light can do the same thing, which is why we encourage people to avoid ultraviolet light from the sun. We certainly don't want to be looking at the sun because that causes both lens and retinal damage. And your eye won't let you do it. If you try to look at the sun on a clear day, your eye will shut down. It's the cloudy days that are more dangerous. Or during an eclipse, when the sun is something you can look at, it becomes dangerous to look at it then. But UV light in itself is injurious as it is to the skin, and it also is to the lens. We like to see people wearing sunglasses when they're out in the sun. Aging itself of that tissue will cause cataract, and diabetes is one of the prime causes related actually to the elevated blood sugar. There are actually only a few things in diabetes that are directly caused by elevated blood sugar. And the cataract of the eye is. Smoking causes cataracts. The abuse of steroid drugs causes cataracts. Fortunately, the treatment is very simple. We remove the lens. You can go in surgically, make a small hole in the anterior portion of the eye, and pop the lens out. Now, that patient can then be treated by corrective lenses, which are usually pretty thick in the way of eyeglasses, or we now have implants, which can be put into the eye and act as an artificial lens. Those are very easily done. They can be placed so that you need very little correction. There are new forms of eye surgery now which modify the shape of the cornea. There are people whose corneas are not absolutely round, and there's laser surgery, which has become very popular, in which scarring is caused by a laser light that's controlled by a computer, and you reshape the cornea. Now, a lot of people like this surgery. It's become very, very popular because there are a lot of people who can throw away their glasses. The problem with this surgery has been that some patients don't get perfect correction, and they've been used to good correction with their eyeglasses, and sometimes once that surgery is done, you cannot then correct it with eyeglasses. Because it is a type of scarring, patients sometimes get corneal flaring. They see lights on their cornea. They find that disturbing. So many people who can get 100% correction with eyeglasses would prefer to stay with the eyeglasses, but there are millions of people who've gone with the new corneal surgery. Other problems in the eye include conjunctivitis, which is a viral infection that can cause eye problems, and herpes ulcers of the eye from the herpes virus can cause scarring of the eye, needs to be treated very aggressively so that we don't do anything to damage the smooth surface of the visual eye where light first comes in. We don't want that light to be distorted before it even gets to the lens. That's the end of this special sense. Next time we'll go on and look at the ear and our sense of balance.